He's not there.
मुंह अच्छी ना
Father, clear light, please.
कथा नहीं सिविल
A very good evening and warm welcome to the President OSOS, to the General Secretary, EC members, distinguished speakers, panelists, colleagues, and the students. It's my privilege to welcome you all to the 6th episode of webinar EyeConnect on ophthalmic files. And today we have the topic of cataract and refractive surgery, advancing precision and enhancing vision. Cataract surgery has undergone paradigm shift, and it is no more a procedure of solely restoring the sight, but has now evolved into refractive procedure aimed at delivering the best possible visual quality and reducing spectacle dependence. Today's cataract surgery is to provide precise refractive outcome tailored to each patient's lifestyle and expectations. With rapid advances of biometry, IOL technology, premium IOLs, flags, and artificial intelligence, the field continues to evolve at an unprecedented pace. Keeping ourselves updated is no longer an option. It is essential to provide evidence-based and patient-centric care. So today's topics are designed to bridge the gap between scientific evidence and day-to-day clinical practice. Experts are there for expert lectures, case-based learning, and interactive discussions. We are there today to explore the practical approaches to challenging situations and learn from the experts. My gratitude to the speakers, panelists, moderators, and Entod for the platform to share this knowledge. With this, I welcome all of you for this webinar. I'll just introduce two of the national speakers and hand over to Dr. Anurag, who is the moderator for this session. So we have with us two of the eminent speakers, all of you may be knowing, the national speakers. Dr. Rajesh Sinha, he'll be joining us a little late. And he is now the professor of ophthalmology in cornea, lens, and refractive services at Center, AIIMS, New Delhi. He has 414 publications, 205 index journals, 5 texts, 5 educational manuals, 87 chapters, and his publications are mainly cornea, cataract, and refractive surgeries. So he has received a lot of awards, to name a few, being the Achievement Award of American Academy of Ophthalmology, Advancement Award of Asia Pacific Academy of Ophthalmology, APAO Distinguished Service Award 2020, SAO Excellence Award at Southeast Asian Academy of Ophthalmology, and many awards and trophies in DOS, IARS, and Ecoin Gold Medal. And he has a lot of orations, some being the SN Mittal oration, Hari Mohan oration, and BN Khurana oration at Delhi Ophthalmic Society. He is currently the General Secretary of Indian Society of Cornea and Refractive Keratorefractive Surgeons, General Secretary of Eye Bank Association of India, and the President of Delhi Ophthalmic Society. So welcome you, sir. We have with us one of the dynamic young, who is all known also Oriya with us, Dr. Praful Kumar Maharana, who is the additional professor at of cornea and cataract and refractive services at RP Center, AIIMS, New Delhi. He is presently the Secretary of Delhi Ophthalmic Society. He has 395 Google Scholar, 163 PubMed Index papers, and more than 50 chapters in national and international books. He has received the Base Surgical Technique Award from Ranho, Australia, Young Achiever Award at ISC KRS, the Ajit Babu Maji Award in Orissa Ophthalmic Society, awards for the best paper in various conferences. He's the mentor of Women Scientific for DBT project, editor of 3 of the bestsellers like Ophthalmology Clinics, Postgraduate Ophthalmology, and he's the editor of DOS Times. He's one of the top scientists to talk about and main work on keratoconus. So welcome you, Praful. And we have with us the youngest and the most dynamic That is, we have Dr. Praveen Subudhi, and he will be introduced by our moderator, Dr. Anurag, along with the introduction of the panelists for this session. With that, I welcome all of you, and we can proceed. I hand over to Anurag to start the session.
Thank you so much, ma'am. Good evening, ladies and gentlemen, wherever you are. Welcome you all to this EyeConnect, scientific webinar conducted by the Odisha State Ophthalmological Society. Fantastic endeavor, fantastic approach to distributing science amongst people who wish to take it. As ma'am has already outlined the flow chart of the session here in this evening, I would take this opportunity to welcome the chairpersons along with Dr. Sucheta Parija herself, who happens to be the chairperson scientific committee of our society. We also have Dr. Ajit Babu Maji and Dr. Santosh Mahapatra, the honorary secretary of OSOS. The expert panelist, Dr. Sudeep Das, has joined already. We are waiting for Dr. Ashok Nanda, Dr. BNR Subudhi to join us shortly as we progress with this session. As we have just heard, cataract surgery has definitely undergone a paradigm shift, and we are looking more at result-oriented, refractive result-oriented outcomes from the simple surgical procedure, which doesn't remain simple anymore. We have to do a lot of planning. We will go to Praveen for enlightening us about the premium IELTS later and how we can achieve all that. But first, let's talk about something wherein all things seem to be lost, meaning situations wherein cataract surgery itself is a little challenging. Getting the cataract out and putting in the IOL. And to speak about such challenging situations and managing cataract surgery in such challenging situations, we have none other than the pride of our soil, Dr. Praful Kumar Maharana from EMS New Delhi. Praful, I welcome you onto the stage. You can open your presentation, start your screen share. We're all waiting to hear what you have to speak in the next 15 minutes or so. Over to you.
Thank you so much, sir, for that kind introduction. And thank you, OSOS, for inviting me. It's always a pleasure to be among my people from my state. And thank you, Suchita ma'am, especially for that. So I'll be speaking on phacoemulsification in difficult situation. And difficult situation means it can be anything, like a difficult patient, a difficult case, difficult cataract, the machine not working. So it includes a lot of things that may not be possible for me to cover here, but I'll stick to my specialty. My specialty is cornea and refractive procedures. So primarily I do corneal surgery. So I'll stick to difficult situation where cornea is causing some problem to you. So when the first and most important is, of course, doing a phacoemulsion in a patient with corneal opacity. The three main concerns when you're operating in a patient of corneal opacities are IL power calculation, visualization, and post-op visual rehabilitation. So I'll stick to the phacoemulsification part. If you people are interested, you can go through this article. There's a review article highlighting all the difficulties and how to counter that. I'll go through a few videos just to highlight the important points. Now, there are two approaches to deal with such cases. Either you go for cataract surgery alone, or you combine it with some sort of corneal transplantation, which we call as triple procedure. So the first, I'll go for cataract surgery alone. So remember, don't jump onto cataract surgery or phacoemulsification in patient with corneal opacity unless you are very certain that yes, the patient is going to gain something out of that. So especially these cases are, this phaco is useful in peripheral opacities, not opacity involving the center of the cornea. And those cases where probably keratoplasty is not warranted or you want to avoid a one-night patient. So such cases you should choose that because keratoplasty is definitely going to give better visual acuity than doing simple phaco with corneal opacity. And visual potential, always evaluate what the patient is going to gain out of the surgery. And one good practical point is if the patient complains you that the opacity is there since a long time, but I have recent drop in visual acuity and the patient is having cataract, and these are the good candidate for planning cataract surgery. Now, these are the few things that you should always remember whenever you're planning a cataract surgery in a difficult situation. Positioning the patient is very important. Don't start the surgery till your logistics are well settled, your ergonomics are well settled. The surgeon must be comfortable to operate in such patients. So you change your position depending on the type of opacity. If, for example, if the opacity is inferiorly located, do a temporal procedure. If the opacity is nasally located, go for a superior procedure. So do your mix and match of your position depending on that. Illumination, always better to use your coaxial illumination and or retro illumination, not the diffuse one. Choose your viscoelastic carefully, not for corneal opacity, but for any difficult case, you have to choose your ophthalmic viscosurgical devices properly. Broadly, for beginners, there are two types you all know, maybe visco-dispersive or visco-cohesive. So whenever you want to form the interchamber, use visco-cohesive. Whenever you want to protect the endothelium or create a barrier, for example, vitreous loss is there, you want to push the vitreous, use your visco-dispersive one, which is your viscoat commonly available in market. Ophthalmic dyes like trypan blue and tricot, it's not a dye, but yes, still people use that for vitrectomy. You should always keep ready in your OR. Ophthalmic tools. What I mean to ophthalmic tools is like iris hook, CTR, capsular tension ring. This should be there when you're difficult, when the situations are difficult. And optical iridotomy is a good addition when you're operating in cases of corneal opacity. So I'll just go through a few videos and tell you few practical points. So this is a case of corneal opacity, post-pterygium scar with secondary keratoconus. You can see here, although in retroilluminescence looking good, but when you're operating, the depth perception is little challenging. So in all this patient, always stay in the rexis as I showed you. And when you're doing rexis in a patient of corneal opacity, always use capsular rexis first. Why? Because if you use a capsulotome and if you leave it flap here somewhere in between, then it may be difficult for you to grasp it. Hydrodissection, a good hydrodissection is a must in all difficult cases. Try to rotate the nucleus, although in this case, the capsule was very fibrous and the nucleus was not rotating nicely. Chopping is almost same, just like you do in routine chops. I'm not going to describe that. But you have to remember, do little bit slow and low. Phaco. Slow and low means keep your parameter a little bit on lower side and don't try to do it in a hurry. So that is an important thing for all cases of phacoemulsification in difficult situation. Putting an IOL in presence of corneal opacity depends whether the astigmatism is regular or not. If it is regular astigmatism, you can go for a toric IOL or else simply go for a monofocal IOL. So now this is a little bit more challenging case. It was a diabetic patient with adherent leukemia post-traumatic and 2 Klocar subluxation. And the capsule was, it was stuck to the intercapsule, iris was stuck. So as I said, you have to be ready with your tools. So here I'm trying to release the adherent iris from the posterior surface of the leukomatous opacity. So when I said tool like iris hook, if your pupil not done iris hook, you can see the dense pigments on the capsule after releasing the iris from the intercapsule. Here you can see I'm using a micro rexis forceps to do the rexis. Why? Because it's impossible for do a capsulotomy. And then I use my intravitreal seizures to cut the capsule. So when the capsule is fibrous, you have to, here an important point I would like to highlight here, a little pause here. You see rexis. So initially I did the rexis, initially I did stain the capsule, but after doing my capsular rexis or capsulotomy, I was not sure where the margin is. So never hesitate to restain. If you're dealing with a difficult situation and you are not able to appreciate the capsule, you can always restain. Go slow and slow. As I said, I'm doing chopping in this patient. So chopping is not that difficult. The only thing is that the visibility and depth perception is a little bit compromised. So don't try to do in the bag phacoemulsification. You can do it in the iris plane. And when the iris is little floppy, you can see these cataract pieces. They may be in angle behind the iris. So you have to be careful enough to remove all such nucleus matter. We call it hidden cataract in our review article. But at the end, you can see my rexis was still irregular because I had to give multiple cut because of fibrous capsule. So what I decided, and again, there was 2 Klocar subluxation. So I put a 3-piece IOL and oriented it along the axis of subluxation instead of putting a CTR because I was not sure about the capsular margin. So in the end, the case went well. But as I said, the ophthalmic tools, they helped me in this case. This is a patient I just operated today's morning and I edited so that I can show you. At times, you may find some tricky situation. It was a post-traumatic cataract. You can see here. The bag capsule is stuck here. This was repaired. You can see some sutures are also there. So it was a membranous cataract. Now, when I stain the capsule, you can see this radiating fold. The capsule was also stuck to the wound here. So what I tried to do, first I released this capsule and bag from this scar behind, from the posterior surface of the scar. Then I attempted to do a rhexis, and luckily I could get a circular rhexis. So it may happen, but if you notice one important thing, what I'm doing is I am ignoring this part because this is not going to help me in putting my IOL. So I am trying to get a CCC done in the center of the visual axis, ignoring whatever there in my periphery, because that is not going to help the patient in visual acuity. So I did a central capsular axis, knowingly that my capsule is maybe stuck, it may be loose, it might have extended posteriorly. Then there was a lot of calcific cataract material, because probably the cataract was there since a long time, and it was a plaque. Now I was trying to lift the plaque using my viscoelastic, and luckily I could peel it off. You can see the complete plaque which was there on the posterior capsule. I could peel it off using the help of visco-cohesive viscoelastic. You may not be always lucky. Now again, what I'm doing, I'm again ignoring my peripheral part. I was cutting this fibrous cataract from the, just corresponding to the rhexis margin. Because if I try to remove it, then definitely the capsular defect will open, then the vitreous will come, and I may have to do vitrectomy and may have to put a IOL in the 3 sulcus. But it was a post-traumatic young patient, 28 years. So my target was let's put the IOL in the bag. So I'm trying to injecting the IOL in the bag. Again, when you're operating in such cases where the bag is compromised, what you might have noticed, I'm not rotating the dialing the IOL. Never try to dial the IOL when your bag is compromised or you're expecting that bag is compromised. Always push with your Silsky hook and just tuck in. This is what we do in pediatric cataract. So just tuck in the haptic instead of rotating. Once that is there, you can see there are some radiating fold in posterior capsule still there. You can see the PC radiating folds are there. However, my visual axis is clear now, and I have placed a hydrophobic single piece IOL in the bag. So I was happy about that. And this fibrosis I won't touch, because here, if I remove everything, then the bag will become unstable, and I'll have to do a pupilloplasty to add on to that. So there are some cases where you have to think and change your plan accordingly. But this is a patient of peripheral opacity. Here, there is nothing much to discuss. But remember, whenever this peripheral opacity, you can see this corneal fold. In such patient, is always a good habit to suture the incision, because it will leak postoperatively. Now, when you're dealing with, so this is a case of corneal edema and phacoems. It was a case of advanced fixed dystrophy with subepithelial scar and epithelial hypertrophy. So as you might have noticed, I debrided the epithelium. That definitely improves the clarity. And incision, staining the capsule, everything is similar to a case of corneal opacity. However, one thing, you can put viscoelastic repeatedly. That gives you transient magnification and improve your visibility. Always use a rhexis for such cases. Don't use capsular tube. Hydrodissection is mandatory, nucleus rotation. And again, go for a low and slow phacoemulsification. We use a term called phacoemulsification in situ. So when you're dealing with cases of corneal compromised cornea, so try to emulsify the nucleus in area where there is some clarity. And as you divide, keep on emulsifying those pieces. Don't wait for 8 pieces to be done and then take out the pieces. So as you divide, you keep on removing the pieces. That releases space in the bag, and the nucleus movement also becomes good. So this is then you can simply put IOL in the bag. Now, this is one group of patients where the cornea is compromised, there is opacity. Now, the second group is your cornea may not have opacity, but there are corneal irregularity like keratoconus. Again, in such patient, visualization, wound and phacoemulsification is a challenge. Which IOL formula to go for? I'm not going to details of that, but remember, for keratoconus, we use this Kane keratoconus formula, which is quite useful. These are 2 of my patients where you can see there was a huge difference when I compared my Kane formula with Barrett's 2K formula. So this gives quite good result. Now I'll show you a video of showing what are the difficulties. And remember, in corneal ectasis, the cornea is thinned out. So go for limbal entry. If you see, I'm going for limbal entry rather than going for a clear corneal entry. And it's better to use, if you're not confident about your topical phaco, it's always good to block the patient. Then capsular staining is a must in all these patients. It's similar to corneal opacity. And one important part that I'll show you here is rhexis. See the rhexis. When I'm trying to do the rhexis, when my instrument is going from normal cornea to cone, keratoconic cornea, see the distortion, right? So that's why in such patients it's very important to use rhexis forceps, because you can hold the flap anywhere, wherever it is floating. With capsulotomy, you have to exactly get to the flap where it is peeling off. So it's good to use capsular rhexis forceps in such patient, and be worried about the distortion of the instrument that happens. Rest of the procedure are same, but here remember the bag and the pupil are little compromised. The pupil, there is dilator muscle atrophy, so it's called breathing pupil. The moment irrigation is on, it will dilate. The moment irrigation is off, it will constrict. You have to be careful about that. When you do a limbal entry, there is ballooning of conjunctiva that can occur. You can simply go with a MBR and do multiple tenotomies, and then the fluid comes out. Then the bag is large. So what happens? These pieces, they keep on roaming here and there and moving freely. So what you can do, inject some viscoat or viscocohesive below the nucleus and some on top of that. So that gives a cushion, and you can do your phacoemulsification smoothly. So these are the few practical tips when you're operating in a patient keratoconus. Putting an eyelid depends whether the keratoconus is stable and astigmatism is regular, or you have to access at 90 degree. If that is not the case, always go for a monofocal non-toric lens. And for those patients who are contact lens tolerant, it's good to go for a monofocal and advise contact lens subsequently. So these are the practical tips. At times, the keratoconus may be a systemic association, like this was the Down's baby. And you can see it was a case of healed hydrops with corneal opacity and a total calcified cataract. And here it was the undilated pupil. Undilated, there was some clear area of cornea where I could see that yes, there is a cataract, and going for a DALK with a phaco would help this patient. If the opacity would have extended till here, then I would have preferred a PKP rather than a DLK. Now, performing DALK is little challenging in this patient because the scarred cornea. I'll not go through the procedure detail. So I do prefer a manual DLK in this patient to go for a partial trephine, do your manual lamellar dissection, and try to remove multiple plane till you think that yes, the corneal thickness is good enough to give a good visual acuity. Now, it was a fibrous capsule. So how to deal with fibrous capsule when you're dealing with difficult situation? The good technique is you take MBR, make multiple entry points, because at times it may be difficult to leave this flap. So make one stab here, one here, one here, one here, one here, and then using your scissor connect these stabs. Then you'll get a good rhexis and with a circular outline. So I'll do multiple stabs, and then I'll use my scissor to cut those, join those stabs. So that will give me a central capsular rhexis, although not circular, but relatively of good size. So that was the plaque I removed. And doing phaco is not that challenging because it was a 35-year-old kid. But the challenge was how to deal with the calcified plaque, because the cataract was there since a long time. So you can see it was a calcified cataract in the periphery. So slowly mobilize this cataract and take it to the center and then remove it. Don't try to pull it from the center. If you pull it, then you may cause a jonular dialysis. Putting the IOL, again, since a DALK was planned, so I put a monofocal IOL, taking a standard K, and then I completed the DLK procedure. So this is one situation where you may, so this was the post-op picture. You can see there was some area of clarity through which the patient could see. So this was the post-op OCT. Then this was one of my video when I was doing senior with Professor Rasik Bajpai. So cases of IFIS or floppy iris syndrome or BPH patient on tamsulosin. So there are different tricks. Pre-op, you can atropinize the patient. Intra-op, you can use Penocan Plus or any mediatic and combination of topical anesthesia. And if you can see, the iris was prolapsing from the starting point itself. So in this patient, use of viscoelastic like viscoat is very useful. You can use viscoat on top of that cohesive like Hilom. That will give a good tamponade. Iris hook, yes, it saves your life. However, it was a very extreme case of IFIS I was dealing with, and it was very challenging. Rhexis with capsular rhexis, yes, as usual. Then phacoemulsification, you can do normal chopping. It's not that a big problem. But this iris threads, this iris strand may keep on coming to your phaco probe. One way is you can simply go in, use your vitrectomy cutter to take out this fiber, or else you continue your surgery as you normally do. Let the fiber come. That's not going to cause any problem because they are atrophic fiber. As you can see here, the fiber is coming. So I'm just removing those fiber, loose dead fibers of iris. So this is IFIS how you deal with. There are Then there is one special case. This is a publication from our center. Interlenticular lens aspect entered disorder. This is very commonly we see being a referral center. So in this patient, as you can see, it was a patient of microscleropecia with interdistal lens, and the capsule was stuck to the posterior surface of cornea. This microscopic MIOCT, intra-OCT picture. So in this patient, I do a modified technique called intralenticular lens aspiration. So make a side port, extend till it goes into the equator and do a capsulotomy. Again, side port and extend it further and create a capsulotomy here. So create two capsulotomy here, and then take your bimanual and go in, and then you can do aspirate the entire lens matter within the bag. See, both my bimanual probe are within the lens, and I am aspirating lens matter staying within the capsule so that my interchamber, vitreous, endothelium, nothing is disturbed. So entire procedure is done within the lens capsule. So that's why the term ILLA, intralenticular lens aspiration. Once your lens matter is aspirated, there is no risk of lens matter draw posteriorly. Then you can simply peel it off using your forceps, intervertebral forceps, or cutter. I would prefer to peel it off, because if I use cutter, I may damage the adjacent endothelium also. So you can gradually peel it off. So in such cases, so entry dislocation lens is there and it's a clear lens, you can go ahead with this technique, or you can simply go with the intracapsular phaco also, such patients. Then third group of patient is with choroidal coloboma or abnormal shape of the cornea. Again, we published this paper in JCRS in 2019. So the challenges in IFC are the corneal diameter is not the normal that we see. It's a pear-shaped cornea. So surgical space is narrow. People often doesn't dilate, and you may have a jonular dialysis or jonular weakness here. At times, there may be lens coloboma. So, and the cataract is unusually hard. It's advanced nuclear cirrhosis. So most of the people, they prefer ECC or phaco, but in that paper, what we found, if you do phaco early, then it can save your life. But if it's an advanced case, go for a SICS or ECC. I'll skip this video. It's a simple lens aspiration. So I'll show you the next video. Again, it was a fibrous capsule. You can see here, you know, and again, a plaque was there. So I'm trying to peel the plaque off. You can see here. So just use a Sinskey hook and try to pull it off, and have some patience. If you wait and wait and wait, then at times you may succeed in taking it out. Then you can put the IL in the bag. Now, this is a more challenging case of IFC phaco. So one thing I wanted to show is here you don't go for a clear corneal incision, you go for a scleral tunnel or corneoscleral tunnel, because in this patient, the angle is little behind than what you see. If you are seeing the limbus here, the angle may be little behind, the surgical space is narrow. So you can do a conjunctival peritomy and make a corneoscleral incision as I am doing in this patient. The rest of the steps are similar to a routine phaco. Okay, the only modification is it's a corneal scleral tunnel rather than a corneal clear incision. While doing phaco immersion, you have to be a little bit careful. Lower the bottle height, keep the IOP on lower side, or as the journal may be jonular dialysis may precipitate it. You can chop this nucleus if you have a little bit of, you have handled such cases. You know how to chop such hard nucleus. It's not a big problem, but you have to use a viscoat cover, or else you may damage the endothelium. To the patient with RD, you can see the glow, total RD. So once the phaco was done on request of retinal surgeon only, we skipped putting the IOL in this patient. So these are the outcomes. These are usually good. So these are the different challenges that one can face with cornea, and you have to convey to the patient this is not the only one intervention. You have to tell them you may need second intervention, because most of the time in India, no matter how much you counsel, the patient expects if I have undergone surgery, next day it will be 6. So you have to tell them complications are high in this group of patient, endophthalmitis, glaucoma. You have to counsel the patient, and you have to tell the patient if the cornea problem persists, then you may have to use a contact lens postoperatively. Biometry, it's a different class, but you remember axial length in presence of corneal opacity, A-scan or immersion is better. Keratometry, you can go for your tomography, or the even recent IL Master 700 also quite good. With this, I'll conclude here. Thank you so much for your attention, and thank you OSOS for giving me this opportunity.
Thank you so much, Praful. A real wonderful plethora, wonderful selection of cases that you've shown us. Can we request you to stop sharing your slides, please? All right. So before I open it, and I see in the participants list that Dr. Ashok Nanda and Dr. Ashwini Behra both have joined us as expert panel. Before I open the session to them and Dr. Sudeep too, just one thing I wanted to understand from you, the two cases that you showed where in one case with keratoconus, you made the entry more limbal. In fact, it was almost clearly if I could see it properly. And in the other, the microcornea with typical iris coloboma, where you also had a sclerocorneal entry. These are not patients wherein the peripheral cornea is supposed to be thin, but is it something that you routinely do in keratoconus? You go a little
In
limbal?
keratoconus, we go limbal because what we
Okay.
feel the keratoconus cornea is not self-sealing. So if you hide it post-operatively, you may have to put a suture if you go for clear cornea. So normally we go for limbal entry in keratoconus patient. And IFC, yes, of course, we go for scleral tunnel only because the surgical space is narrow. If you go for a clear corneal, then you have to operate like this, which becomes a little challenging while chopping the nucleus. If you're like this, you can easily chop it. So in IFC, yes, scleral tunnel. In keratoconus, that was advanced keratoconus. If you would have noticed when I'm moving my rexus fossa, there was distortion almost near my incision site. So that in that case, the thinning was still almost reaching limbus. So in that case, limbal entry was that was the only way out in that
Yeah,
patient.
that's exactly what my question was actually. So it's not universal for all keratoconus. This was
Yes,
an advanced keratoconus, so you chose a different path.
yes, yes. If it is a central cone, you can still go for a clear corneal incision.
Right. So Sudeep sir, anything to add from your side? Sudeep sir?
No, nothing really. I mean, very interesting surgeries, and interesting to see the intraoperative OCT along with the surgery. So I know you can have a very small view on one of the eyepieces, but does he really use that? Because I find that more distracting than anything, having in one of the eyepieces the image.
No, sir. Normally, I prefer to see the monitor rather than through my side eyepiece. That can be
Yeah,
customized.
correct.
Yeah.
Yeah. Yeah, I know that. So that's what I was also doing when I was using that.
Ashok sir, anything to add from your side? Are you there?
Very common we see in a referral center. So in this patient, you can see it was a pain.
Do we have Dr. Ashok Nanda here in the? I think he had joined. I saw
Yeah,
him.
I'm there.
Yes, sir. Anything to add from your side, sir?
I just have one question, nothing to add because Praful had explained almost everything. Just one question. If a patient with keratoconus would come to you for a premium lens, let's say a toric or a EDOF lens, what are the contraindications where you would say no to the patient?
Sir, for toric, you have to have two axes at 90 degree and that all things. Once everything is settled, if you are sure, then please ask the question if he is a contact lens tolerant patient. If the patient has used RGP previously, then he will always be dissatisfied with the toric lens that you put. So in such group of patient, I would definitely avoid putting a toric IOL. Rather, I'll go for a monofocal followed by RGP postoperatively, and that is exactly where the patient is very happy. If you put a toric IOL, then they keep on asking you, it's not useful. They are not happy with the quality of vision. Then you then advise a RGP, then they're questioning if you have put a toric, why RGP? So such group of patient I will definitely avoid.
Right,
And
right.
yes, it has to be a stable keratoconus.
Yeah,
And the
ghosting is very
second,
common. I mean, I have had a patient who kept on complaining about ghosting in spite of putting a T4. Patient did not have very significant keratoconus, but still the patient was not happy with toric lenses.
the
Do you
higher order
also look at the
aberrations,
EKR Praful in keratoconus? Do you also look at the EKR map before you decide on a toric IOL for a keratoconus, even if it's stable and the astigmatism appears to be regular?
To be frank, I haven't put a toric IOL so far because I'm
Okay.
happy with monofocal. But yes, EKR readings are useful. But I think the latest IL Master 700 keratometry is quite good enough to know exactly what K readings are there. You can watch the journey K analysis map, because if the patient is having higher order aberration above the third order, then in such group of patient also toric IL is not that useful. Patients still keep on complaining, this ghosting, all this thing.
Not only that, the thing is the axis may not be just 90 degrees apart. They may be different. And the other
Yes,
thing
so
is,
one
it could
thing,
be
yeah.
and the other thing is it could be steeper on one side of that. And so you'll be correcting the IOL will be right across. It'll correct right across that axis. While here, half of the meridian will be one and the other will be something else. So it's
So one
very,
very
very
important
dicey.
thing, yeah. All
I use the
NX
EKR, but not so much for the toric IOL. For the power calculation, if I had access to a pentacam, I would use the EKR. Yes.
especially post-refractive cases, people prefer EKR
Yes,
reading.
Yeah.
post-refractive you have to use.
Correct.
I mean, I'm
Correct.
just asking whether for keratoconus routinely you would be using that or not.
The
Very glad that
keratoconus,
you also lamented
one
the
point,
importance of the Keynes formula, Praful, because I sincerely believe that that's the best that we have
yes,
in our
that's the
tool
best.
as far as keratoconus is concerned. The other advantage is it has the central corneal thickness, the CCT and the lens thickness as optional input. So you may not put them in and still it'll give you a proper reading. What's interesting about the Keynes formula is it asks for the biological sex of the patient. I don't know how the algorithm is built into the formula, but I mean, experimentally, if you choose or click the biological sex to be the male and the female with the same readings, you might get different results. So
With
it's very, very
0.25 to
interesting.
0.5 difference is
Mm.
there. And one
Ashwini,
thing,
yeah,
one thing just I would like to add,
yeah,
Pentacam,
yeah.
all the practitioners, they have to remember, most of the tomogram, they presume a lot of things. So if they are just like, so I think Sudeep sir was telling you, the pentagram may be showing some axis, it may be actually different. So this is because the pentagram might have presumed that this axis may be this axis may be that. So that part you have to remember. Even if it's showing you two exactly 90-degree axis, the actual axis may be different.
Thank you, Praful. We'll end this section for now and come back later if we have
Thank you.
time to discuss more. Thank you so much for an elaborative and really enlightening, focused talk on cataract surgery in challenging situation. Moving on, I saw that we have Professor Rajesh Sinha joining us. So, sir, do we have you with us? Are you ready? Rajesh, sir, are you ready?
Yeah, I'm just opening up my slides.
So Professor Sinha is going to talk to us on managing subluxated cataracts and the general concepts and his way of handling it. So can you start your screen share, please?
Yeah, I'll just do that. I'm really sorry for joining
Thank you
late.
so much for joining us, sir. We can
Part of-
see that you look exhausted, but still you could adhere to your, that shows your love towards Odisha and us. Thank you so much.
People like you force others to love. We can't think of anything else apart from loving you, because you're such a fantastic person, not only a great surgeon, a great human being. So thanks a lot, Dr. Anurag, and thanks a lot, Dr. Suchita, for having me here in this nice webinar. I'll be talking about managing subluxated cataract. I have no financial interest. There's a general rule that if it's less than 4 clock hours of subluxation, then or zonal adhesions, then we can do a phaco with endocapsular ring, and that will maintain it. If it's 5 to 7 clock hours, then scleral fixation of the bag by use of Sione's ring or by use of these segments, along with phacoemulsification, and the IOL implantation in the bag is done. And if it's more than 7 clock hours, then we have to remove it completely and do a scleral fixation of IOL or an AC IOL or an iris claw lens, which is coming up these days. In older individuals, yes. In younger individuals, I will be a little hesitant in thinking about iris claw. because I have seen cases wherein there are many cases that I've seen wherein there has been disinclination of this iris claw lens. However, all these rules are there, but it also depends on the nature of the case. Like if somebody is having, say, 5 to 7 clock hours of zonal dehiscence, we can fix the bag if, say, it's a traumatic subluxation, traumatic zonal dehiscence. We can fix the bag with a Sionis ring. Double Sionis ring is always better. Single Sionis sometimes can cause a striae in the posterior capsule, and that sometimes may not have a very good centration. But if it's a progressive zonal apathy with a 5 to 7 clock hours of zonal dehiscence, I would rather remove everything and do remove the capsule as well. Obviously, try to do a phacoemulsification in the bag, or maybe bringing the nucleus in the anterior chamber and then remove the bag and then go ahead and do a scleral fixation of IOL. So it also depends on the kind of case that you have. Mostly we should, most of the cataract surgery that we do under topical anesthesia. But if at all we have to think about doing any fixation of the bag by Sionis ring or a segment, or doing a scleral fixation, it is always better to block, put a peribulbar or a subtenon block. Subtenon block is a very good technique, very good method to bring complete echinacea and also pain-free situation with less amount of xylocaine and less amount of anesthetic agent, and also having less of the positive vitreous pressure. So subtenon block is something which I would definitely prefer over peribulbar. But sometimes or many a times we do go ahead with peribulbar, because the peribulbar block is mostly given by our residents outside the OT, outside the the sterile zone, and by the time you're doing other surgeries, the patient is blocked. So it's just a case of an inertia, or just a case of being a bit lazy, that you depend on peribulbar. Otherwise, if you start giving subtenon block, you will really love it. We should always maintain anterior chamber, because whatever zonal dehiscence we have, it will progress if the anterior chamber becomes repeatedly shallow and deep. If there's vitreous in anterior chamber, we should do a small amount of vitrectomy in that area, and then we should inject dispersive viscoelastic over that area, so that something like Viscoat containing chondroitin sulfate, again, no financial interest, and that blocks the area wherein there is zonal dehiscence. So that really helps. And then you initiate a small capsulorhexis away from the site of subluxation. And then, of course, you can go ahead and enlarge it later. It's always better to initiate from area of intact zonules. The force should not be opposite the area where the zonal dehiscence is present. The force should be towards the area of zonal dehiscence, so that you don't cause more traction towards dehiscence. We don't cause traction and more damage of zonules by your movement of instruments. Slow motion phacoemulsification should be done, low vacuum, low flow rate, minimum bottle height, so that there is less of turbulence, less of deepening of chamber, or less of shallowing of chamber whenever you are, when the parameters are high. In such cases, there are chances of fluctuation in anterior chamber. There are also chances of fluid going posteriorly through the zonal dehiscence area, and that results in shallowing of chamber, and then you have a tendency to further increase the bottle height, increase the IOP, and then further that causes shallowing. So all these things can happen. In such a scenario, in case it has happened, then a very good method of reducing the pressure is by using a trocar cannula. Place it in the pars plana region, just place it, do a little bit of vitrectomy, so that the whatever fluid has gone behind and it's pushing the anterior chamber, pushing the lens iris diaphragm anteriorly, it will fall back, and that works. And just leave that cannula there, so that whenever there is any fluid going behind, it will slightly ooze from that area and the chamber will be formed. So these are important things that we have to follow. We should do good hydrodissection, but we have to be gentle. And power should be enough for the density of nucleus. Power should not be low. There's a tendency that people do keep slightly lesser power, then it has more of a pushing tendency, and that can cause further damage to the zonules. But as far as IOP is concerned, we should keep IOP on the lower side, the bottle height or IOP, whatever. It should be on the lower side. It should not be high. And whenever you are aspirating, it's always better to use bimanual cortical aspiration. And the movement of the IA tip should be tangential. It should not be radial. Otherwise, there's more risk of zonular dehiscence. Now, this is a case wherein there is a traumatic zonular dehiscence of close to 100 degrees, and so in such a case, you can manage if you have been able to do the surgery without increasing the dehiscence. You can manage with an endocapsular ring. Now, there are two ways of doing it. Some people prefer putting the endocapsular ring and then they go ahead and do a nucleotomy and cortical aspiration. Some people prefer putting a lens hook. Here, I don't have a lens hook, so I'm going with the iris hook only. But when you're putting an iris hook, it's always better to put the hook at the posterior limbal point so that you don't pull the capsule too much anteriorly. And of course, keep the IOP on the lower side so that you don't stretch the capsular bag too much. Otherwise, there's risk of ripping of the capsular margin. And now, when you are removing the probe, you should always inject viscoelastic from the side port so that the chamber doesn't become shallow. And you can see here that the zonal adhesions has not increased, so you can manage with the help of endocapsular ring, and that it will suffice, and IOL can be placed in the bag. Now, if the zonal adhesions is a bit more, something about 120 degrees, in such a case, you can manage with Sionis bag fixation. Now, in such a case, in a case of a traumatic zonal adhesions, with of this much extent, you can manage with a single eyelid fixation or with the use of a segment fixation of bag. And of course, as you can see here, bimanual irrigation aspiration is being done, and a 9-0 proline suture needle is used. The knot is tied around the eyelet of this of the Sionis ring, and then the suture is taken out from a groove made 1.5 millimeter behind the limbus. The ring is placed in the bag, and the small attachment, the eyelid that is with the eyelid that is there, it should be above the capsular margin, so that when you tighten it, it should come over the capsule. When you are placing the IOL should not be dialed vigorously. Rather, you can gently caress the haptic into the bag and then remove the viscoelastic. Now, in this particular case, I would prefer doing a fixation of the bag with the help of a Sionis ring. But sometimes, in this particular case, I'm only doing the case. Unfortunately, there was some fluctuation in chamber, and while I was just finishing the procedure, there was a small capsular tear. So in such a case, if they put PC tear, so if there's a PC tear, it is not advisable to put a ring, fix the bag. Otherwise, it will stretch it further. So in such cases, as you can see here, the capsule is quite intact in this region. So you can do a one-sided suture fixation. So this is a lens, specially designed lens with the eyelet and the haptic, meant for suture fixation, suture scleral fixation. So what you can do is that you can place one haptic on the capsule and the other side you can fix. So only thing you have to be careful is that don't tighten the suture too much, otherwise you will pull the IOL on one side. So you have to be careful. Titrate the centration of the IOL and then put more knots, and then you can remove the capsule that is there in the central part, because what will happen that this lacks capsule will definitely fibrose and it will create problems later. If the subluxation is so much and it's a progressive zonulopathy, in such a case, it is always better to remove the lens completely and do a intrascleral haptic fixation of IOL. So for this, initially we create a flap and a groove adjacent to it. So this is a technique which I have modified the standard glue technique described by Professor Amar Agarwal and Dr. Geber Shariat. Make 2 incisions and then with the help of a crescent blade, I extend the dissection beyond the second incision so that the haptic remains in the same plane when you sterilize and place it into the groove. And this is the intrascleral, intralenticular aspiration of cortical matter, which was described in 2002 by us. The advantage is that you just make 2 openings in the capsule, and then with the irrigation port, you can stabilize the lens and also hydrate the lens matter, and with the irrigation aspiration port, you can aspirate the lens matter. So it helps in removing the lens matter completely without falling of lens matter behind. And then an intrascleral haptic fixation is being done. And that is how you can see a well-centered IOL. Now, if you have a decentration of IOL, femtosecond laser does help. Flax is a good technique. You can see here there was subluxation. I'll show once again, this is the area of subluxation. So if you do a flax, so part of the procedure, part of the steps are already done. So the complete capsulotomy has been done. You don't have to do anything. Then you remove the capsule, place hooks, and then stabilize the lens. Then see whether there is any vitreous here or not. There is a vitreous here. There is some amount of vitreous here. So that has to be removed. And so a small amount of vitrectomy is done. And then phacoemulsification is done. And once the whole nucleus and cortical matter is out, then endocapsular ring is being placed, and then an IOL is placed in the bag. And once the IOL is in the bag, you can remove the remaining viscoelastic, and that is the end of the procedure. Now, this is the last situation which I would like to show is that it is a case wherein the lens is subluxated, but in large majority of cases, the zonules are lax and not damaged. And that is a condition which is microspherophakia. So the lens becomes spherical and it pushes the iris, and in a large majority of cases, you can manage with the help of endocapsular ring. But there are certain cases wherein the lens was subluxated anteriorly above the iris, and then in such cases it is always better to remove the lens completely with the bag and then do an intrascleral haptic fixation of IOL that I had shown. But in many cases of microspherophakia, you can manage by maintaining the chamber well and doing a slow motion aspiration of the lens matter, and the zonules are lax. So later on, after removing the lens matter completely, you can stretch the bag with the help of endocapsular ring. And in a large majority, it works well. But yes, we have seen cases wherein the subluxation was more and there was some damage of the zonule as well. In such cases, it is better to remove the lens matter along with capsule and do an intrascleral haptic fixation. But in cases wherein we see that these zonules are all intact, all sides, but they are lax, and mostly it is seen when you have a uniform swelling of the lens and it is in the center. This means that it can be managed with an endocapsular ring. So these situations are really challenging situations, all these subluxated cataracts. It requires a good preoperative planning and of course, execution intraoperatively of whatever you have planned in a meticulous manner is very essential, and that brings out a good result out of in these cases. So thank you very much.
It's always lovely to see those steady pair of hands, sir. I've personally, when I was growing up as a surgeon, I used to watch your videos with awe just to see the stability of the fingers which hold the instruments to perform the surgery. Fantastic exhibition once again. Ashwini, if you're there, we would like to start with you. Your comments or questions, if you have any for Rajesh sir. Ashwini?
Hello, sir. Good evening, sir.
Hi, good evening.
Sir, namaskar, sir.
Yeah.
Sir, Howler surgery. I just had one doubt regarding last couple of presentation. Let's say a patient with one-eyed 6x6 pseudophakic, the other eye has paracentral corneal opacity with 8-10 diopter astigmatism, 12 diopter, but it's not able to measure. And let's say you don't have corneal topography, how to approach, your approach would be in that case, maybe a little bit of surgical PI might improve the vision, but since other eye is 6x6, a residual high astigmatism might not help the patient much. So how to go about that, sir? If you can enlighten.
Okay, you're asking me?
Yes, sir. Yes, you, sir, Professor, both.
Okay. See, it depends on the location of opacity. Now, if the opacity is in the peripheral part of the cornea, then toric IOLs, I mean, we have customized up to 11 diopters of cylinder for a peripheral close to limbus scars wherein it works well, the toric IOLs. Now, as you said, the opacity was paracentral. In such cases, many times the toric IOLs may not work that well. So it's better to do a cataract surgery, place a monofocal spherical lens, and manage the patient with a contact lens, RGB contact lens. Now, if the opacity is almost close to the pupil on one side, almost covering the pupil, then again, when you are doing a cataract surgery, again, you will not place a toric lens, you'll put a monofocal non-toric lens, because with a central and paracentral opacity, the toric lens may not behave that well. So in such cases, we have done a study long back in the year, published in the year, I think 2003 or 4. We can just do small sphincterotomies. So if the opacity is covering the pupil, say 80% of the pupil, and you do a little bit of sphincterotomy, so it will just make about 2 to 2.5 millimeter of pupil just adjacent to the opacity, and it will also not reach the IOL margin. So, I mean, that is, I think, a good way of handling such cases. And if the patient can tolerate RGB contact lens can provide even up to 6.6 or 6.6 partial vision after, doing cataract surgery, putting a monofocal non-toric lens. But if you have put a toric lens, then RGP lens will not work in these cases. Why? Because when you have put a toric lens, you have already taken care of the astigmatism. And when you are putting an RGP lens, it neutralizes the corneal astigmatism. So there will be a bizarre outcome. And so it is not advisable to use RGP contact lens in such cases. So peripheral opacities, many of these cases do very well. They will reach up to 6.9 vision unaided with a toric, or even 6.6 partial with a toric lens. But the central paracentral opacities, I'll be a little hesitant in doing a toric lens. Rather, I would do a non-toric spherical lens and try to manage such cases with an RGP contact lens. Try to convince the patient. Some of the patients may not be, ready for it. That is one thing that has to be explained to him. If it's a very high astigmatism, but still, I would say a central paracentral opacity, I'll be a bit hesitant in toric IOLs.
Thank you, sir. Sir, Professor Anurag, sir, your opinion on that?
Yeah, we'll come to that a little later. I think Dr. Sucheta wants to ask something. She just unmuted herself. Ma'am, you want to ask something?
Yeah, as usual, a very good presentation. So I have one question from you, sir. Sir, what is your take on the techniques of glued IOLs or a flashed IOLs, which for this, which do you prefer and what are the advantage in these cases?
Technique of?
Glued eye.
So glue diamonds and flange scleral fixated
Flange.
lens.
Okay. Yeah. Both the techniques are good. We have just recently done a comparative study, a thesis given to one of my candidates, and both the techniques are good. The advantage of the glued or the intrascleral haptic fixation of IOL is this, that the haptic is all inside, intrascleral. So mostly it is not subconjunctival, but in a flange technique, even if it goes to the tip of the tunnel, the scleral tunnel, just the external point is still subconjunctival. And the thing is that in some of the old individuals, the tenons is absolutely atrophic. So it is very much visible underneath the conjunctiva, and that is a bit of a concern for me, but mostly it works well, doesn't make much of a difference, but still I will be a bit hesitant. I mean, if I have somebody, my own patient, I would prefer doing an intrascleral haptic fixation than the flange technique. However, there are certain conditions wherein flange technique has an advantage over glued technique. One of the indications is cases of megalocornea, wherein the cornea is large, and when you are doing this intrascleral haptic fixation, you have less amount of haptic to put it. Now, there a modification that we have published a year before was a modified technique was this, that we created a tunnel at the limbus only and created a small iridotomy in the periphery, and from there the haptic was exteriorized and then it was tucked. But still, I would say that is one indication wherein flange technique has an advantage over the intrascleral haptic fixation, because the risk of slippage is less. Because in such cases, even if you are able to tuck the haptic nicely, still the haptic is a little taut. So once in a while, if it's a child and the child rubs and there is mild trauma also, the slippage can be there. But if it's a flange technique, it will not slip. So, I mean, all these techniques have some advantage and we have to use it to the best of our advantage for our patients. So all these techniques are there. I mean, but yes, in a routine case, I have done this comparative study and I have slight, inclination towards the intrascleral haptic fixation.
But that's a very interesting perspective, sir, in megalocornea and rubs. I mean, it's really something that intrigued me. I'll just ask for a quick opinion from both of our very senior surgeons, Ashok sir and and Sudeep sir. If it comes to external fixation of the bag, what would you prefer? Would you prefer a normal CTR with a CTS, or would you prefer a Sioni ring with eyelets to fix the bag? Out of these two, what would you prefer generally? Both of you.
I prefer a CTS, because
Okay.
sometimes one thing is very easy to position it in the right place. And a Sioni ring tends to be a little more rigid sometimes than a normal CTR. So I've had cases where it sort of rips the entire bag away. So rather put a CTS, there are various ways of reducing pressure in that. And then sometimes you need two CTS. So instead of using a 2L Sioni, it's much easier to use two CTS segments. And for me, that's very much easier.
Ashok sir, yeah.
I also probably would prefer a CTS only if the subluxation is less than 180 degrees. But if it is more than that, then I prefer Sionis, because there is a equitable distribution of the jointular tension, 360 degree. And of course, inserting is a little more difficult, but then I think that's a preferable thing I prefer.
Thank you so much, everybody.
No, I always use a CTR along with the segments, never a segment by itself.
Yeah.
Always a CTR along with the segment. One question I had for Dr. Rajesh is, he puts a CTR in microspherophakias also. Does he use a small ring or how is it?
Yeah, it actually depends on the age of the patient wherein I am operating. And if the axial length is, say, normal size, then see, it is very difficult to exactly predict because of the zonal laxity that how much the back can be stretched. So axial length is something which is a guide that helps us that probably the dimensions are all correct, but the zonules are lax. That's why there's microsphericity. So if the axial length is normal, then I'll go for a 13-11. If the axial length is smaller, then I'll go for 10-12.
10-12. That's true. Absolutely. Thank you so much, sir, for that nice discussion and presentation. We move on to the last segment of today's webinar, which is concerning refractive cataract surgery. And refractive cataract surgery these days are almost defined by the use of premium IOLs. To speak about the premium IOLs and selecting the right premium IOL for the right patient, we do invite Dr. Praveen Subuddhi, our very own prolific functionary from the southern part of Odisha. Praveen, you can start sharing your screen, show us your slides, and take us through what you have to tell us.
Praveen, unmute yourself.
You're muted, Praveen.
Yeah. So at the outset, I'd like to thank Suchita Madam and Anurag Bhai and all and the OSOS for giving me this opportunity. And after the two nice presentations about the extremes of cataract surgery, what I will be speaking will be on the day-to-day basis what we perform. Around 95 to 98% of our cataract cases are very simple, very normal cataract cases. And selecting the right IOL is of paramount importance. As we have already discussed, there has been a paradigm shift in the management of cataract surgery, how it used to be 20 years, 25 years back and right now. So now our target is always to make the patient the best of the lenses which is available at our disposal and give him a majority of spectacle-free vision. So nowadays we have this trifocals, and this is a very nice meta-analytical study which was published recently in 2024. And it has categorically said that it is very important to select the appropriate IOLs based on the lens characteristics and patient needs. So whatever IOLs are there, we need to identify what are the patient needs and accordingly select which IOL to be implanted. Coming to the different types of premium IOLs which are present in our disposal, one is the toric IOLs, which is the most commonly performed intraocular lens, which we use in cases of corneal astigmatism. If the patient is having a preoperative corneal astigmatism, then it's better to implant a toric IOL. And some cases where the patient has some form of pathology in the posterior segment, there you can give EDOF lenses where there are no rings, so it gives an enhanced intermediate vision. Multifocal IOLs is one of the best lenses now at our disposal, and it is very nice, which gives you the distance, intermediate and near visions. And enhanced monofocals in cases of critical cases where you are doubtful about the outcome, then in those cases enhanced monofocals also has a very good role. So the premium IOL, what is the goal of the premium IOL we need to know? So somebody So what is the goal of the premium IOLs, which we need to know? It improves the spectacle independence. So we need to promise less in these cases. Whenever we are implanting a premium IOL and to the patient, we need to discuss these things to the patient. What are the things we are offering? And we want a good contrast sensitivity, especially for surgeons, like for ophthalmic surgeons. If we want to undergo cataract surgery, we need to have a good contrast sensitivity because we are operating under the microscope, and maximize the uncorrected visual acuity. For that purpose, we need to have a proper preoperative evaluation. We need to, if there is a immature lens, Hence, we need to check the refractive status. We need to see the degree and axis of astigmatism, whether it is correlating with the corneal astigmatism or not. Because if there is high disparity between the corneal astigmatism and the total astigmatism, that means you're dealing with something lenticular astigmatism, or whether there is any subluxation is there or not. It's a good tool. Target refraction, how much target refraction you want to give in the post-operative period. Sometimes patient you can give, if the patient is not ready for ring dials, you can give for monovision preferences. Like one eye you can go for the distant dominant, you can go for the emmetropy, and the other eye you can go for near vision. And more important, when you're selecting the premium IOL, you need to assess the lifestyle of the patients. So you have to check whether what is the work environment, whether he's more on computers, whether he's on outdoor activities, what are his hobbies and activities, what are his driving habits and his reading frequency, because this gives a clue to you, so which lens to be implanted into the patient. Ocular health, as Dr. Prafulla has showed in his so many good videos regarding the corneal opacities and surgeries in the presence of corneal problems. You need to check if there is a keratoconus. If you're suspecting keratoconus, you need to do a corneal topography before the cataract surgery. It will give you it will help you in identifying whether the patient is having keratoconus or not. Retinal status, if there is an advanced cataract, if you are missing the posterior segment pathology, then you would have promised something to the patient, you won't deliver after the surgery, and it leads you to the medical legal problems. So retinal status has to be assessed before performing this, before taking up these patients for premium IOLs. As I said, the lens-induced astigmatism, if there is little bit of mild subluxation is there, you need to identify beforehand, because if you identify on table and if you are promised for a multifocal IOL, and if you don't properly implant the lens, the patient will have post-operative refractive surprise and halos, and the patient will never be satisfied. And previous refractive surgeries, if he is performed, you need to ask the patient certain times. You can't identify whether the patient has undergone LASIK or not. So you need to ask the leading questions. If your patient tells, very nice, but if it doesn't tell, then you have to check whether the patient has undergone any corneal surgeries. Visual functions, very important for me, is the pupil size in good light ambience. If there is a large pupil, I won't prefer a multifocal IOL. For me, it's better to go for EDOF or a monofocal plus. Scotopic vision needs, and angle kappa is definitely a important thing for me if I'm taking up these patients for multifocal IOLs, because if there is a large angle kappa, whether it's a positive or a negative, if it is more than 0.5 mm, you will definitely land up in post-operative refractive surprises and the unsatisfaction of the patient. And in this study, they had shown that the angle alpha doesn't play much critical role, but the angle kappa plays a very critical role in selecting the patients for multifocal IOLs. When you're counseling these patients for premium IOLs, you need to understand you need to discuss with the patient about the realistic goals and how much spectacle independence you are delivering to the patient. And where you should not tell this patient that you will be having halos. Sometimes when you ask this patient, they will be whether you are after implantation, if you ask them whether you're facing any halos or glare, they will tell yes, yes. Sometimes you should not ask these questions, but if you are implanting the multifocal IOLs and if the patient is an outdoor traveler and drives a lot, then you need to tell this patient that these lenses may have little bit of halos and glare. So that's why it's preferable to go for a non-ring dials rather than ring dials. And budget considerations in this part of the country where we are staying, budget considerations plays a critical role in selecting the type of premium IOLs. Whenever you are planning to implant a multifocal IOLs, you need to have a careful evaluation of the posterior segment. Any form of macular pathology, sometimes a small vitreomacular traction, which you might not see in clinically, but in OCT you can pick up. These cases are big no for any form of multifocal IOLs. Any form of small lamellar holes or AMDs or drusens, which may progress to become a wet AMD. These cases are definite no for a multifocal. And patients with advanced glaucoma, again no for a multifocal, because the patient already has a compromised contrast sensitivity, and with multifocal IOLs there will be still a compromise of the contrast sensitivity. Corneal irregularities, if a small irregularity scar or anything in the paracentral or the central region, if you are seeing, if you have missed and if you have advised this patient for multifocal IOL, again it will be a big task for you to convince the patient post-operatively. unrealistic. When you discuss these things with the patient regarding the multifocal, you can assess the patient's expectations. If there are unrealistic expectations, then definitely a big no. Then it's better to be on the safer side, go for a non-ring, EDOF or a monofocal plus. So these are some of the steps which I follow. So first I see the astigmatism, corneal astigmatism, how much it is. Anything above 0.5 or a 0.75, I will definitely go for a toric. If there is less than 0.5, night driving is important, then I will go for an EDOF. And if the night driving is not important and patient stays in the indoors like a female patient and he wants a better near vision, yes, then I will prefer a multifocal. And if the patient is having an high expectations with his budget conscious and balanced vision and some form of macular disease, then I will go for a standard IOL and will not go for a premium IOLs. Whenever you are considering premium IOLs, it's better always to have a good biometries. Nowadays, we have the best biometries in the market. And whatever the biometry, now the technology is based on the swept source. And the outcomes of the swept source biometries, it gives a very good results and predictable results. Else, whether it is Argos or whether it is IL Master or whether any instruments nowadays is mostly swept source, and it's better to invest in this instrument because it gives you a better outcome and enhances your private practice. Lens power calculation, and with these instruments which we have, these equipments which we have all the formula at our disposal. But what they have according to the American Academy, what they have studied, that the Barrett's Universal 2 has the lowest prediction error for all the IOL models. And if you have instruments like the Varion technology and anything, in these cases, it will be helpful because sometimes you need a good central capsular rhexis while performing the surgery. In this case, if you see, the patient is highly uncooperative. So sometimes the capsular rhexis won't be proper, but if you have the central mark of capsular rhexis, then you will be in that direction, and you can centralize your capsular rhexis, and then the alignment of the IOL and at the end of the procedure will be very good, and the patient's visual outcome will be as you expected before the surgery. So what makes you happy is a 0 in your autorefractive error in your autorefractometer in the postoperative period. If you see a 0, perfect 0, that means whatever the efforts you have given, that has been met and the patient is extremely happy, and that is the target. And with the help of all the instruments which we have right now, this type of target refractions of 0 are quite possible and quite repeatable also. So let's go to the different case scenarios. The first case, if the patient was an active 55-year-old executive, he is a computer engineer, he has a 1.5 diopter of astigmatism and has very high expectations. So what I thought, it's better to implant a toric EDOF IOL because it gives you a good distance vision and an intermediate vision, which serves the purpose of that patient. Second case, a doctor by profession, but the patient has a tonic pupil. That means the pupil doesn't constrict properly. So, and he's an avid reader also. High frequency night driving is there. He has an astigmatism, corneal astigmatism of 0.4 diopter. He's concerned about the halos because the pupil diameter is a little bit large. So I thought of performing EDOF lens because it gives a superior contrast and acceptable near vision with the near glasses. And I've told him that with +1 or 0.75, he was getting N6. So the case 3, a female teacher who is an avid reader and there is no significant astigmatism, wants independence of glasses. So in this case, it's an ideal case for a multifocal IOL because it gives you an independent for most of the tasks, and occasional glasses for small fine prints. But the patient was very happy because his near vision was without glasses, because as the patient was an avid reader, and these patients are extremely satisfying for you as well as for the patient to implant a multifocal IOL. But sometimes whenever you're implanting a multifocal IOL, you need to tell the patient about the adaptation period. Sometimes because the patient may not be happy, because he may not be able to read the near vision as was expected before the surgery, as you had told the patient. But within 1 to 2 months, the adaptation period starts and the patient starts reading without any difficulty. And the counseling for neuroadaptation is very, very important. And nighttime halos or glare, which are very common with multifocal, but it goes off in a few days, and that you need to counsel these patients. When with the good lubricating drops and with the improvement of the corneal health, definitely these halos comes down. And we need to reinforce a realistic expectation in these patients. So to summarize my presentation, premium IOLs offer a very excellent visual outcomes. But when we are selecting these patients, we need to be very careful, because sometimes a wrong patient selection will ruin your practice and will give you sleepless nights. Individual needs must guide your choice. Multifocal, EDOF, and toric options each have their own merits. And a proper counseling before the surgery is very, very important whenever you're implanting a multifocal IOL, and tell them regarding some amount of glare and halos. Don't tell too much, but little bit, so that they can understand that this is okay and it stays for a temporary period and it goes off within few days. But whenever you're implanting multifocal IOL, you need to understand the eye, you need to see the ocular health. If the ocular health is very good, then only prefer a multifocal IOL. If the ocular health is not that good, it's better to go for an EDOF or a normal monofocal plus. So thank you for the kind attention.
Thank you so much, Praveen. If you could just stop sharing your screen and we can have everybody on board. Fine. Superb, Praveen, as usual. We really enjoyed the talk and plenty of learning points to take from there. Now, needless to mention, all of us who practice premium, everybody does everything for every patient before even thinking about a premium IOL as a selection for that particular patient. And despite of all our efforts, it's also needless to mention that we do have around 50 to 60% of the patients who do not show that they're very happy with the product, at least for the initial 2 to 3 months. Neuroadaptation could be one of the reasons, but I want to ask all three speakers and our expert panel and Sucheta ma'am, Ajit sir, whoever is there on board, answer me briefly, sharply in one word. What do you find to be the commonest reason of patient dissatisfaction despite a proper, optimal placement of the premium IOL and optimal result on the other side too? What's the commonest cause of dissatisfaction that you find? I won't call it a dissatisfaction, but a very mild grumble. Everything is okay, but you know that but you know is followed by what most commonly?
The vision is not very crisp, slightly faded vision, but not really a problem for most of my patients.
So that's contrast. Contrast is what
Contrast.
is.
Correct. Correct.
Okay, so Ashok sir, what's your experience?
I feel most of my patients do complain of negative dysphotopsia as a problem. Even multifocals, actually they complain more because their expectations are high. But negative dysphotopsia is, I think about 20% of my patients still complain that I feel something is obstructing. I have to, keep my mind off it. Otherwise, it keeps bothering.
That's in all IOLs.
Yeah, that's okay. But then multifocal people have more expectation.
Yeah.
They complain more.
Yeah, that also varies with the make of the IOL to an extent too. I mean, what's the sharp edge, the square edge is like. Rajesh sir, what's your opinion? What's the commonest cause you find?
Well, the commonest problem that these days I face is that either it's a multifocal or a monofocal or an EDOF. Most of the patient, I mean, I am happy, but the patient is not happy. The reason is that the patient says that everything is fine, I can see, but there is that two things. Either one is that irritation and watering because of dry eye. Second is that there is something that I want to clear. I blink and I do something. I mean, I can read. I'm reading everything. I just told that, okay, you can read 6/6, you can read N6, everything. No, but something I want to clear up. And that is probably because of many cases of undetected MGD, wherein thin, when you see there is some few bubbles seen in the tear film, that is a sign that is suggestive that MGD is taking its toll. And that is one reason why many patients, they are not very happy. I mean, apart from all these, all these things that, some patient can say that there is some glare or whatever, but all these things you can explain and you can tell them, you can talk to them, a good chair time can sort it out. But this one thing I'm trying to work hard to sort out. Some of the patients are still not very much
Dry
convinced.
eyes, you mean?
Yes, dry eye and MGD. That is
MGD.
one problem that
Okay.
many
Okay.
patients. I mean, the quality of vision also deteriorates with the premium IOL if there is some element of dry eye, some amount of MGD that is there.
Sucheta ma'am, same question to you.
Yeah, for me also, see, commonly I see these cases, so I give them regularly some kind of lubricants, and some of them are happy with it. But what Dr. Rajesh Sinha was saying, most of the patients are happy with 6/6 vision, yet they say something is wrong. So that is what if you see, we have done actually a study and finding it out. Yes, there are some sort of dry eye in these cases, and I preferably give them all lubricants so that I don't have too much of unhappiness to hear about. And one more thing is, yes, some patients will be complaining to you about halos and reduce contrast sensitivity, not much, but yes, halos sometimes they give. So that's my take.
But your standard prescription includes a lubricant only for the trifocals, or you give it to monofocal patients as well?
Yeah, to
For me,
monofocals also. Yeah, to monofocals also.
But
yeah,
they
these
don't
days I
have.
have also started in all the patients.
Absolutely. Okay. Praful, what would you add? What in your experience is the commonest cause? You're muted, Praful.
As most of the panelist members said, is glare halos, and nighttime driving is also a big problem with few of my multifocal patient. And one thing I would like to tell you a short story. There was a dietitian where we put a multifocal IOL. She went back and she studied on the Google, and then she came and she started saying that I exactly am seeing those many rings that was there described in the Google in my IOL. So that part also has to be taken care of when you're counseling the patient. If you are counseling them too much about the glare, halos, dysphotopsia, somehow there is a psychological effect. I feel they start saying those things. So that is also a very common problem among this group of patients, especially with high expectations. And lubricating drop, yes, there is no harm. I have also started using that because invariably 50 to 60% of patients they have some foreign body sensation after cataract surgery. So it's better to use lubricating from day one.
Raveen?
But I prefer
Alex?
CMC only, not sodium hyaluronate, CMC
Yes,
0.5%.
yes. As watery as you can. Yeah, that's true.
Whatever the panelists have said, everything was fine. So one thing I need to add, I think certain patients of mine complain of the floaters. So
Yes.
sometimes which have not seen the floaters or PVD before the surgery, which is not visual, and after the cataract surgery, they always say that I am seeing a black spot in my field and I'm very much dissatisfied. So that is the difficult part for me to explain to the patient that this is there before the surgery and you need not worry and you need to make it out of focus. And that is the difficult part. The floaters part I feel very difficult to explain to the patient. It was not there before surgery and it is now present after the surgery.
One common question again, and I would again, transfer myself from one baton, passing on the baton from one speaker and one panelist to the other. Do we see all trifocals from all manufacturers performing the same way, or do we have a list of our preferences, not financial interests taken into consideration, quality wise, performance wise? Do we keep a list? If we use multiple products, do we keep a list and choose which patient to be given what, basically based on how much that patient is important to us? Ashok sir, I'll start with you because I know you use many. So I'll start with you. Do you think all trifocals perform the same, or there's a difference as far as the performance is concerned?
No, there is definitely a difference in the outcome. And to me, of course, Panoptics is the one which is consistent in almost all cases. But in case the patient is little worried about halos and glares, my next choice, or rather the first choice, where patients are night drivers or are interested not to have any glare, is probably the Raynor Galaxy. The rest from other are, depending on somebody wanting to have a lower package, obviously, that's the choice. But in the premium, these are the two I choose, depending on whether somebody wants good near vision at a cost of, some amount of glare and halos, or some amount of compromise on the near vision at a cost of better night vision.
So Ashok sir's verdict is Panoptics is the best performing and the most stable performing trifocal in the industry, and we are not holding any industry talk here. Anybody in the panel who has a different opinion than this? Anybody who finds a trifocal to be equally performing or performing even better than the Panoptics? Once again, it's just not a verdict. I just wanted to know your opinions, and for good.
Actually, it's difficult to exactly say because I mean, you'll have to do a study comparing all these trifocals to
So it's
know the
your experience, sir.
quality.
Yeah.
As far as experience is concerned, you always try to play safe. And definitely when you have a patient who is very well off, and you are a bit scared that this patient may complain, then you like to go with the most reputed IOL and the most reputed company that is available. So that is one reason why we always have this I would say, I don't know whether we should call bias or we should call it over reliance on Panoptics, because obviously Alcon is definitely the leader in the field of IOLs. But yes, as far as experience is concerned, I have used other trifocals as well, and they have also done quite well. So, but yes, I haven't done a comparative study as far as quality of vision. Quantity of vision, most of these lenses they do well. Quality of vision only is sometimes the surface texture it decides, it governs to some extent the quality of vision. So the surface texture sometimes, obviously, it may differ between different companies, and so that is something that we need to know. I mean, that's a good question that you brought forward, and that's a food for thought for all of us to maybe start doing a study comparing all these trifocals.
Sudeep sir, you've implanted zillions of IOLs, and if I may ask you, out of these three, I mean, the three IOLs of focus when it comes to presbyopia correction, the trifocals, the EDOFs, and the enhanced monofocals, the monofocal pluses, if a patient is prepared to pay, can any of these three IOLs be considered as a universal suit all IOL? I mean, without thinking about anything, if the patient is prepared to upgrade, just go in and put even an enhanced monofocal. Can this be compared in terms of quality? What's been in your experience like? Can they be compared to monofocals?
I mean, enhanced monofocal is a monofocal plus is a monofocal. So you really see that now some people somehow do a lot better than expected. Mostly they work as a monofocal. So I use zillions of Eyehances and Clarions, Tori versions also. So I mean, I actually don't even give them any expectations on anything better. So I think the counselors tell them it's better, that's all. But between the other two, of course, there's a huge difference. Between EDOFs and this, it's a huge difference. So I also tend to probably go with EDOFs a little more than I would earlier, but I really haven't had that much of problems with multifocals. And especially so in Kerala, I find people understanding, I don't know what it is, the literacy level, the understanding, I don't know what. Like you talk about, like Praveen was talking about floaters. It was a big problem when I was in Odisha. Here, it's not at all a problem. You tell them and they understand. I let them see, I've been seeing it for 15 years. They said, okay, fine, no problem. And they don't complain much of halos either when they're driving, and almost everyone drives. You told them beforehand. So once you told them, it's like, you try to drive a Lamborghini on a bad road. How is it going to be on potholes and all that? Not very great. So you have expectations of what it is, what you can do and what you cannot do. And once you tell them that, they're fine. They're absolutely fine. So if a person wants to read a lot, and Malayalis will want to read a lot, so they cannot live without the newspaper in the morning. They have to read multiple newspapers and a whole lot of other things. So actually I go with for me, I have always been happy with the Panoptics. I came here and realized that they're using a lot of synergy, which I hadn't really used earlier. And I found people are happy with it. Recently, I started using symmetry.
Perhaps
That's a big who extremely happy.
yeah. So your connection is a little unstable, but I
But
could tell that
normally,
you started using.
not really.
Okay. So many things to discuss because these
Okay,
topics,
line looks good.
each of these three topics that we discussed here tonight could actually constitute a whole webinar of 1.5 years, 1.5 hours duration, 90 minutes duration. But we had to end at some point, and I think the time has come. So we will end it here. Plenty of discussions. Thank you so much, the speakers and all my panelists. Back to Sucheta ma'am for the vote of thanks and conclusion. Thank you so much. I hope you enjoyed the session as much as I did. Thank you.
Thank you. It was great, and discussions can go on, but still we don't have time. So I call upon our General Secretary, Dr. Santosh Mahapatra, to give the vote of thanks.
Thank you, ma'am. Good evening, one and all. I was thoroughly enjoying the whole discussions, and all the speakers were fantastic. And for the first time, being the post-segment surgeon, also all the anti-segment people who are here as speakers are personally known to me, so it is more enjoyable. And I would like to thank our Chairman Scientific Committee, Dr. Sucheta Parijat, to design such wonderful webinars. And this is the 6th on the row. And thank you all for being part of it, all the chairpersons, including Dr. Ajit Babu Maji. And when Dr. Anurag Misra is the moderator, we are all sure that the label of the webinar or seminar or any CME is much higher. So he has all the points to coordinate and discuss in such a way that all the points what need to be conveyed is conveyed to the audience. Thank you, Anurag, for moderating the session in such a nice manner. And I would like to thank each of the panelists who have contributed to the scientific discussion so elaborately. And last but not the least, all the speakers, starting with Praful, Professor Rajesh Sinha, and Praveen, our own Praveen, for giving such nice topics which have enhanced the scientific content of the webinar. Thank you, one and all. And at last, I have to thank Entode for providing us the platform. Thank you all.
Thank you.
Thank
you
you,
very
sir.
much.
Good night.